So Monica is an allied health professional academic, specifically a physiotherapist, who specialises in the development and evaluation of complex physical and psychosocial interventions for people living with chronic long-term health conditions. She originally trained as a clinical physiotherapist in South Africa, and then she moved to Wales, where she was awarded a PhD in 2005. She later secured a Welsh-based NIHR post-doctoral fellowship. The impact of her research was recognised by 2 successive Health and Care Research Wales Senior Research Leadership Awards. Now that is an acronym, since 2022. Monica is also a certified executive coach. She holds a European Mentoring and Coaching Council Practitioner Accreditation and has been a UKRI Future Leaders Fellows Fellowship Network mentor since 2021. She's supervised many PhD students, mentored postdoc clinical researchers, and secured prestigious external fellowships, including a Wellcome Trust Career Developments Award and NIHR Advanced Fellowship. Monica is joining us tonight to speak on how a systematic approach to the development and evaluation of complex interventions is critical to advancing the field and how important it is to ensure equitable access to effective interventions for all who need them. Welcome, Monica. The floor is yours.
Thank you, Louise. So I think you can hear me. So I didn't get a Wellcome Trust Fellowship. I helped somebody else get one. So that's the important bit. I've chosen to speak tonight about the active ingredient in rehabilitation and really thinking about understanding what works for people living with long-term conditions. And that's primarily because I've spent a lot of time thinking about that and trying to understand what it is that, why some people do well, do better than other people, and actually what's kind of important to them. But I still can't quite believe that I'm here at King's. I kind of go, as I cycle from my train from Paddington, because I still live in Cardiff, and I kind of thought, well, I'll share with you just a little bit about how I got here. So I started university at the age of 17. I don't know why, but anyway, I was 17 in 1990, and that was a really pivotal time in South Africa. It was at the end of apartheid, and I was my eyes were being opened to a whole new world that growing up I just didn't know about. And so I went to Stellenbosch University, not because I could speak the language, I couldn't, but because I wanted to get away from living with my parents. There was absolutely no kind of, I just needed a bit of freedom. And so I spent the first year of university walking around with a dictionary, because what happened was our lecturers just translated English textbooks into Afrikaans. But after my first year, we went to Tygerberg Hospital. So that's this first picture up here on the left. And it just looks like an ordinary hospital building, but it's not. It is a building that is divided in 2. On the one side was where white people were looked after, and on the other side was where black people were looked after. And so, as students, and when I got there in 1991, that rule was enforced. By 1993, when I graduated, apartheid had come to an end, and we were learning to work differently. And we were sort of experiencing that time where actually care was different. But that left me with the real kind of awareness about the importance of equitable healthcare. My first job, as I qualified, was in Karadi District Hospital in Pinehurst. It doesn't exist anymore, it's been flattened. But it was a spinal cord injury hospital where people came from their acute injury, which wasn't what people generally would have, why people might in this country end up with a spinal cord injury. It was typically people who had had gunshot injuries or stab wounds. So there was a lot of trauma, and there were quite complex injury presentations because of the mechanisms of injuries. So we would work in teams. We worked from acute care in the morning, intensive care, all the way through to rehab. in the afternoons and out into the community. And I learned a huge amount there about caring for people across the range of their conditions, but also about the social situations and circumstances in which they lived. I then went and worked in the US for a year. It was a state-funded rehab facility that I worked in. And even though it was state-funded, it was just dramatically different. I mean, we had hoists, we had just all sorts of equipment, we had teams working together, we had group homes, we had supported work environments, and I kind of went, whoa, what's this all about? I went back to South Africa after that, and I spent a year working as a clinical educator for the University of Cape Town, where I did all my clinical visits in the informal settlements just outside of Cape Town, and often having to go into work under police escort because of the time that it was. But at the same time, I met 3 Irish girls, and they opened my eyes to kind of like, maybe I think I need to do a bit more than what I'm doing here in Cape Town. And actually Jenny's here today, so thank you, Jenny, because I think if I hadn't met you, I wouldn't have thought about, maybe there's more to learn. Anyway, nevertheless, I ended up in London. And for those of you, a lot of you are here from South London, so you might recognise Ward 7 at St Peter's Hospital in Chertsey. I don't know if any of you do. I think it's also been flattened. And interestingly, with Ward 7, it didn't look terribly different to Conradi Hospital. So, yeah, I'm not sure what that says about where I was working in terms of access to facilities and rehab, but I think things are better now. I think there's a new building there. I worked there for a year. It was my first experience of working in the NHS as at that time, a senior 1 physio. And then I was also doing my master's degree, and then I ended up working at Kingston St George's, where I met John and Geeta and Fiona as a lecturer. And there was a poster up outside our boss's door, which was advertising a studentship in Wales. And I was like, oh, that's interesting. Hadn't really thought about doing research. Anyway, I thought, let me drive down the M4. So off I went in my Renault 5, and I went to go and see what Cardiff was like. Never been there before. At that point, I wasn't really sure if I was staying in the UK or if I was going back. And I went to an interview with Professor Wiles for a PhD studentship, and Mark is here also in the audience today. So I stayed. They wanted me to stay. I stayed in Cardiff, and I stayed in Cardiff for the 3 years of my PhD, and then I stayed for another 20. So, and from Cardiff I've come here. So I think it's sort of a natural progression, but here I am. So, my PhD. So my PhD was, I think, relatively, I think in hindsight now, kind of really influential, but also relatively simple, asking a relatively simple question about what people can do versus what people actually do, what they do. And that was the conversations that we used to have on the, I think it was the 7th or 8th floor of University Hospital Wales, where Professor Wiles at the time, I wasn't allowed to call, afterwards I wasn't allowed to call him Professor Wiles anymore when I finished. I remember that conversation. But he said, well, what do you think people can do versus what they do? And we did this really simple activity monitoring study at the time. Well, it was, and I think it was probably, we were some of the first people to actually start measuring activity. In 2004, we actually published this paper, which was around how many days a week do we need to measure activity to be able to say it's representative of what someone does. At the same time, I was also in a lab, where a human movement analysis lab, which really showed me the difference between being in a lab and bringing people into this laboratory, which with lots of equipment and techniques, but actually didn't tell me anything about what people really do. And that opened up for me the question in rehabilitation, and why I think it drove my further research, which is, why is it that people do what they do in their rehab, and what is it that makes the difference? So after my PhD, Mark said to me, you need to find your thing. And I remember that conversation clearly. He said, let's go and meet some people. You need to find your unique piece of research. You've had your training now. Now you go out and develop your thing. So I met Anne Rosser, who's also here today. So thank you, Anne. Anne introduced me to Huntington's disease. And I spent the next, I think, nearly 18 years fully embedded in this world of Huntington's disease. And it's a really unique disease, relatively rare, I'd say, but I think probably everyone in this room now will have heard of it because of the breakthroughs that there have been in the last couple of years. And I would say those breakthroughs have been a lot in part from the work that has been happening in Cardiff under the leadership of Professor Rosser. So Huntington's disease is an autosomal dominant disease. That means that if you carry the gene, you will develop the symptoms. And that means that it's somebody who carries the gene, who's tested for the gene, you can study over time. As a physio, I had learned about movement. I hadn't learned about all those other things, about the cognitive problems, about some of the behavioural issues. I hadn't learned about genetics, and I hadn't learned about end-of-life care. So I had to learn all these new things. But one of the things the question that I asked was, surely we could be doing some activity here. Surely exercise might make a difference. And it could logically have, but we didn't have any evidence to say that it did. And we didn't have any trials or any way of saying, actually, exercise was good and safe. And the reason we needed to do that was because this protein, or the Huntington protein, is expressed throughout the body. And we didn't know at the time whether that was going to be safe or not. So this was 2007, and we started off with a review where we said, okay, well, what do we know about Huntington's disease? And we asked the question, can directed activity actually improve mobility in Huntington's disease? We started to study the presentation, so the phenotype, and we started to say, well, actually, what is walking like? And we quantified falls in the disease. We also started to think about how you measure outcomes of physiotherapy. So we did a Europe-wide study where we looked at what kind of outcome measures, which typically we would use as physiotherapists, could be used in Huntington's disease. And then with a PhD student, my first PhD student, we did a feasibility study of home-based exercise for people with Huntington's disease, which had really positive results. We also then said, okay, well, we're going to carry on, and what we know as physiotherapists, because this is what we think is right to do, we're going to do some training, we're going to train people. Well, we had this, we went from this amazing positive results to a negative trial. The task-specific training trial, we got all this funding together and it didn't work. And we went, well, this doesn't make any sense. So what we did was we went and asked the people who were living with Huntington's disease what mattered to them. This was probably this was something that was relatively early on. Nowadays, people in the audience who are involved in research will know that public and patient involvement and engagement is absolutely crucial to everything you do in research. But at the time, it wasn't. So we formed this group called the Wales Huntington's Disease Involving People Group, where we sat down and we spoke to them and we said, well, what matters? What do you want us to do? And we learned very early on that actually it wasn't about training. That people wanted more variety, they wanted some choice, they wanted something that was more suited to their interests. So we went on and we designed a second trial, which was a randomized trial, also a feasibility trial, where we put in place a multimodal exercise intervention. So we said to people, okay, if you want to come to the gym, we'll meet you, we'll give you a taxi, we'll bring you to the gym, and you can come to the gym twice a week. If you would like a recumbent bike in the home, we will get a bike, and we will bring it to your home, and we will send people to come and help you use it. And I did have 15 bikes that are, I think, somewhere, still in Cardiff University, I don't know where they are, but anyway. We may have donated a few of them we got donated, but so this trial had better results because actually what we were doing was saying, let's help you find the exercise that you want to do, but we were still looking for an exercise effect. People did well, but then you know what? Once we stopped, and we stopped supporting the exercise, we stopped saying, we'll send a trainer to the gym with you, or we'll come to your house and see you at home. These people were coming into clinic, and we were in clinic, and they stopped as well. So that informed my question around my NIHR post-doctoral fellowship, and that was around how do we develop sort of self-management support? How do we think about the coaching aspect, about how do we get people to continue to change or sustain that kind of activity? And that ended up being a six-centre trial across the UK that we ran. But we also, what we did in this, and it was the first time, was we started to think about logic models. We started to really carefully define what was it that we were putting into the interactions, and what were the activities, and how did they then map to what we were expecting to see as outputs and outcomes. And we produced workbooks, and we trained the therapists who were delivering the intervention to make sure to encourage them to think about the way they were speaking and encourage sort of a coaching style conversation. That work came together in clinical recommendations to guide physiotherapy practice, and these were published in 2020 in Neurology. And actually, I think we can say for the first time that people who were living with Huntington's disease and physiotherapists actually had a resource that they could go to where there was some evidence to support their practice. Alongside that work, we were also still continuing with the wearables work, because that had kind of stuck with me, this idea about can-do versus do-do. We did quite a lot of work on how wearables can help us to assess balance and posture, to look at what we call movement signals. We also then looked at, well, what does it mean then when people are wearing the devices, and how do we monitor, and how do we sort of engage with people when we send these devices at home. And we asked people their views about using these devices, because this is becoming much more and more important about what matters to people. We developed systems where we could take, for example, a Fitbit and stream it through a data platform so that we could get the data on the other end, but people could actually have their devices. And we also worked with concepts around text messaging to remind people to say you haven't charged your device, because we could see the device was not being worn. So we had ways of prompting through that. But the big challenge here was what you do with the data, because there is so much data that keeps coming, and the challenge around missing data, how you manage it, and there's challenges around the ethics of monitoring. So there was a lot that we had to kind of think about. That actually, what's great now is that there are a lot more people thinking about these challenges, because devices are a huge part of what we do. We use in healthcare and in rehab. And then beyond Huntington's disease, I also started then working around taking these concepts, these principles around patient and public involvement and co-designing and developing logic models where you really define the inputs and the activities, to applications in multiple sclerosis, sort of in progressive multiple sclerosis, where people were perhaps excluded from typical rehab programs because they had more advanced disease. We also looked at these concepts in trials of rehab following hip fracture, and currently we've just randomized the 710th person to a trial of self-management support in older people with osteoarthritis and multiple long-term conditions. I'm going to tell you just for the last part of my talk about one trial that we published on last year, and that's the LISTEN trial, the LISTEN intervention. So the LISTEN trial was funded in 2021, really as part of a program of work that NIHR funded when there was a greater recognition around this new phenomenon called long COVID. In the absence of any real understanding about what that condition was, and in the absence of any standardized interventions or trialed interventions, we used an approach where we co-designed and evaluated a personalized self-management support intervention, because what we had learned, certainly, and what we have learned, is that actually personalized interventions are what matters. But this was based on the evidence from Bridges self-management that Fiona, who is here in the room, could tell you a lot more about than I can. If you want to talk to Fiona, but she's here. But so what we did was we reframed the self-management support that people needed as part of their rehabilitation in the context of recognizing that there were over 200 symptoms of long COVID. And we used that to place their narrative central to the intervention, so that the intervention was drawing on the collective lived experience and the expertise of those people who had navigated that pathway. And we then went on and evaluated the effectiveness and the cost effectiveness in a randomized trial with 554 people living with long COVID. I won't talk to you about the clinical outcomes, suffice to say that they were all significant. We showed a significant improvement in all the sort of clinical symptoms that people were experiencing, particularly in fatigue management. But actually what was really interesting in a really short trial, that this intervention was less costly and it was more effective, so the concept of it dominated usual care. There were lower private healthcare expenses and people missed fewer work days. The key point from that is that actually it was the personalisation. When we did the process evaluation, we really looked into what was working and what was mattering to those people. It was the tailored intervention to the personal goals and contexts. But really important, because we've spoken about randomised controlled trials and robust methods, is that there's this real tension between how do you personalise intervention but still make sure that the intervention is being delivered in a way that it's intended, because we're not dealing with a drug that you can say these are the components, so we need to understand what those components are. And part of that is saying actually we need to really train practitioners delivering this intervention in the concepts and the principles. So we were able to do that. And what that meant was that those participants were able to reframe what getting better meant to them, because they were living with a long-term condition. And what they really valued was being listened to and heard by those practitioners. So we're going on to do some more work. We're building on that work now here in King's. And we've been really lucky to secure some accelerator funding from the Better Health and Care Hub, which is hosted within the Faculty of Nursing, Midwifery and Palliative Care. And what we're looking to do is take that work in long COVID and look at that across a variety of post-infection conditions, because what it's taught us, what long COVID has taught us, is that infections can, for some people, take a while to recover from. They can result in persistent and episodic symptoms after that acute infection. And despite that growing recognition, we don't really know about how these post-infection conditions are assessed and managed in primary care. So that's what we started to look at, and we've been doing some work on community engagement. We've done a survey with practitioners working in primary care, and we're also doing a scoping review to really understand what's going on. And we hope that that's going to help us take that work forward in future grants that are aligned to the NIHR priorities around work and health. So just to finish off, back to South Africa. Actually, this is Botswana, but it's close enough. This is a baobab tree. I think probably people will recognise a baobab tree, but what you might not know is that it's a succulent. And that's really interesting. So it stores its water in the trunk. And that means that it can bear its fruit in the dry season. For me, it's a symbol of rehabilitation. It's got really big roots. And what that means is that when we think about our rehabilitation practice, we need to be grounding our practice in the context in which it's working. It's not what it looks like on the surface, and that's where the logic model idea comes in, to say, actually, we need to think about what is underneath the surface. So, you know, for me, that's kind of the model. And then, you know, I said I finished my physiotherapy degree at the time when apartheid came to the end. That stuck with me. That stuck with me, that importance of equity and health. And Mandela became president in 1994. We were all there at the polling stations. And there's a word in South Africa which is Ubuntu, and that word captures Mandela's gift, which is his recognition that we are bound together in ways that are invisible to the eye, and that we only achieve ourselves by sharing ourselves with others and caring for others around us. And that's something that I want to bring with me to King's, to my role in the faculty, and to work with the colleagues that I'm working with. And I hope that I have brought that to the people that I have worked with in the past. And I've mentioned a lot of the people here on this slide here today. They've done that for me. You know, they've been there for me. And I think just to finish off, Ian's here. Those of you who know me will know that I can get a bit overexcited. And Ian's my grant. He's my, you know, this is from a long time ago, but, you know, he's always chilled. And he's always like, it might not happen. So, yeah, thank you, Ian.
So big thanks to Monica for that. I want to point out that two of our professors seem to have a connection with St George's. I've also worked at St George's in 1990s, and I know Julie, who's over there, also worked at so you've got an association to be tracking with our next statistical modelling. I'd like to welcome Richard back to the podium.
Thank you. Thank you very much to Glenn and to Louise for introducing our inaugural professor lectures this evening. Huge thank you to Stephen and to Monica. It's such a pleasure to hear about the journey that's brought you to us, and we're delighted that you are with us, so thank you very much. But even more so, look forward to seeing you in a moment for the wine. But before the wine, I would like to invite our two speakers this evening to look surprised as we pass you the flowers that are over there, please. Thank you very much. They're both